In this presentation, we're going to be talking about the structure and function of the renal and urologic system. We'll start with the kidneys, which are a pair of organs located on each side of the vertebral column. And this is in the peritoneal space, which is the abdominal cavity behind the peritoneum. And you have the upper and lower poles extending from the 12th thoracic vertebrae to the 3rd lumbar vertebrae. And on the right, the kidney is slightly lower and palpable because it's displaced downward by the overlying liver. Each kidney is about 11 centimeters long and approximately 5 to 6 centimeters wide. It's actually a pretty thick organ as well, about 3 to 4 centimeters. We have a tight adhering renal capsule that surrounds each kidney, and this is embedded in the mass of the perirenal fat. And the capsule in this fatty layer is covered by fascia composed of fibrous tissue. We also have adipose tissue providing a cushion and helping the kidneys to stay positioned between the abdominal organs and the muscles of the back. All of this also helps with the protection from trauma. Now we're going to look in the internal structures of the kidney. First, recognize where the hilum is located, and you can see that it's medial, and it's this indentation in the kidney where the entry and exit for all our blood vessels are located. Alongside the blood vessels, you'll find nerves, lymphatic vessels, and also the ureter. The outer layer of the kidney itself is called the cortex. The medulla forms the inner parts of the kidney, and within the medulla you have several regions. Each of these regions are called pyramids or renal pyramids. Renal columns are an extension of that cortex, and it extends into each of the pyramids to the renal pelvis. We also have minor and major calyces, which are these chambers that help to collect or receive urine from the collecting ducts, and they form the entry into the renal pelvic area. The renal pelvis itself is an extension of the upper ureter. Now, the lobe is the structural unit of the kidney, and each of these structural units or lobes are composed of its own pyramid and the overlying cortex. In one kidney, there is anywhere between 14 to 18 lobes. The functional unit of the kidney, this is called the nephron, and each kidney has approximately 1.2 million nephrons or functional units. It's a tubular structure. It has subunits as well, and the subunits include the renal corpuscle, the proximal tubule, we have the loop of Henle, the distal tubule, collecting ducts, and all of these are going to contribute to the formation of urine. They also contribute to our electrolyte balance, as you've seen in the prior lectures on fluid and electrolytes. Now, these different structures of the epithelial cell lining, they have various segments of tubules that facilitate all the special functions of secretion as well as reabsorption of fluids and electrolytes. The cortex specifically contains the renal corpuscle, where most of the proximal tubules are located as well, and there are some segments of the distal tubule located there. The renal pyramids located in the medulla contain the loop of Henle, the collecting ducts, and we know that the kidney has 3 kinds of nephrons. Okay, so not only do we have 1.2 million types of nephrons overall, but there's 3 different types. The first one is called the superficial cortical nephron, which makes up the majority, about 85%, and they extend partially into the medulla of the kidney. The mid-cortical nephrons with short or long loops are located in the kidney, and we have the juxtamedullary nephron. This only contributes to about 12% of the nephrons, and they are very close to and extend into the medulla, and they're important because their function is to help concentrate our urine. So let's look up what specifically makes up the renal corpuscle. It's comprised of the glomerulus, the glomerular capsule, or sometimes called the Bowman's capsule. We have mesangial cells and the Bowman's base. The glomerulus is a tuft of capillaries, and they loop around that Bowman's base. And it pushes around like if you were kneading dough. Mesangial cells, they look like smooth muscles. They're going to secrete what we call the mesangial matrix. This is connective tissue, and it lies between the glomerulocapillaries, and it provides support to those capillaries. But mesangial cells also have a phagocytic ability that's very similar to monocytes. They release inflammatory cytokines, and they can contract to regulate our glomerular capillary blood pressure. It's really important to understand the glomerular filtration membrane, and it has 3 layers. It's the intercapillary endothelium, we have the middle basement membrane, and then of course the outer layer, or the visceral epithelium, and this is where we have a layer of capillaries. This capillary endothelium has cells that are in contact continuously with the basement membrane, and there's pores. The middle basement membrane is a selective permeable membrane. The epithelium has specialized cells, and we call these cells podocytes. And this term comes from pedicles or projections that radiate and adhere to the basement membrane. These pedicles will form adjacent podocytes that interlock, and this interlocking is going to form this network of intracellular clefts called filtration slits. The endothelium basement membrane and the podocytes are covered with protein molecules, and these protein molecules have an ionic charge or negative charge, and this ionic charge helps to deter the filtration of anionic proteins, so it's going to prevent proteinuria. The glomerular filtration membrane will also separate blood within the glomerular capillaries from the fluid, and it's filtrating within this Bowman's base. This membrane allows all the components of blood to be filtered, with the exception of our blood cells and our plasma proteins with the higher molecular weights, like our plasma proteins. The glomerular filtrate will then pass through the 3 layers of the glomerular membrane, and it will form the primary urine. Now we're going to talk about the juxtaglomerular apparatus, and it is supplied by afferent arterioles, and it drains by the efferent arterioles. Okay, so again, the glomerulus is supplied by afferent arterioles, but then drained by efferent arterioles. And it's a group of specialized cells known as the juxtaglomerular cells. They release renin, and they're located around the afferent arterioles where it enters the glomerulus. But between the afferent and the efferent arterioles is the macula densa, and these macula densa cells can sense sodium within the distal tubule. Together, the juxtaglomerular cells, the macula densa cells, are the sodium sensing cells, and the mesangial cells, they're going to form what we call the juxtaglomerular apparatus. Control of our renal blood flow, so the blood flow within the kidneys, our glomerular filtration, and how renin is secreted, all happens within the juxtaglomerular apparatus. Now we're looking at the renal tubule inside the nephron, and you can see here the proximal tubule actually continues from this Bowman space, and it has this initial convoluted segment and goes straight down, descends towards the medulla, and this wall of the proximal tubule actually consists of a layer of cuboidal epithelial cells, and on top of the cells there's an extra surface layer of microvilli, and we sometimes call this the brush border. This is really important because it allows for more surface area. So more space for reabsorption to occur. And this is the only structure inside the nephron where cells are covered with this microvilli. Now the proximal tubule finally joins the loop of Henle. You see this down here. And this is going to extend into that medulla space. The cells of this area are very thick and they're cuboidal, and it helps with the active transport of solutes, but it does not allow the transport of water. Now we have this thin ascending area. So ascending means going up. And this is still part of the loop of Henle, but now it's moving towards the upper part of this renal tubule. And it's going to start to narrow in. And this area is composed of thin squamous cells. So there's no transport function in this area at all. This distal tubule has a straight and convoluted segment also. We see it coming here, and then now it's going to drop back down. It's extending from that ascending loop of Henle, now going into the collecting duct. This duct is a large tube that descends down the cortex of the kidney and through the renal pyramids of the inner and the outer medullae. It's going to drain urine into the minor calyces of the kidney. Now, in the distal tubule, the principal cells will then reabsorb all the sodium and secrete potassium. Remember, they have an inverse relationship. And we have intercalculated cells that are secreting hydrogen, and then they are reabsorbing potassium and bicarbonate in trade of or in lieu of. And now these cells are important because they're going to help with the maintenance of fluid and electrolyte and our acid-base balance. The kidney has its own set of blood vessels that derive from the abdominal aorta, specifically the fifth branch of the abdominal aorta. And these blood vessels run very closely and parallel to the nephron structure itself. And when the renal arteries meet at the renal hilum, they are divided into anterior and posterior branches. And then they're going to subdivide even further into each lobe, and we call these lobar arteries. They're going to supply the blood to the lower, middle, and the upper thirds of the kidney. We also have interlobar arteries, and these are lobar subdivisions that travel down the renal columns and in between the pyramids, and they are going to form the afferent glomerular arteries. We also have arcuate arteries, and they consist of branches of interlobular arteries at the cortical-medullary junction. They're going to arch over the base of the pyramid, and then they run parallel. Glomerular capillaries consist of 4 to 8 vessels, and they are arranged in this big convoluted fist-like type structure. And they come from afferent arterioles, and they empty into the efferent arterioles. They're going to carry blood to the peritubular capillaries. They are the major resistance vessels for regulating intrarenal blood flow. Okay, so they have a lot to do with the intrarenal blood flow in the renal blood flow that helps to regulate our entire blood pressure system. Then we also have peritubular capillaries, and they surround the convoluted portions as well of the proximal and the distal tubules, along with the loop of Henle, and they're adapted for cortical and juxtamedullary nephrons. We also have the vasa recta. It's a network of capillaries that form loops, and they follow the loops of Henle, and it's the only blood supply to the medulla, the vasa recta. And this is important because this area is going to form and concentrate urine. Our renal veins, if we have arteries, we need to have veins as well. The veins follow the arterial path, but then they're going to reverse in direction. They have the same names that correspond to the arteries. They're just called veins. And they eventually are going to empty into the inferior vena cava. The lymphatic vessels also run and tend to follow the distribution of the blood vessels in this area as well. Ureters are important structures that run about 30 centimeters long, and they intertwine with the smooth muscle bundles. The urine that's formed by the nephrons are going to flow from the distal tubules and collecting ducts through the papillary ducts to the renal papilla, which are projections of the ducts, and to the renal calyces, and this is where it's collected into the renal pelvis. Well, the urine has to be funneled then into the ureters to eventually get to the bladder. The lower end is going to pass through the posterior aspect of the bladder wall, and this close approximation is important because it permits the direct transmission of electrical stimulation from one cell to another. It's going to result in downward peristaltic contraction, which means just like we have peristalsis in our GI system, it's trying to propel. Well, we're trying to propel urine from the kidneys downward into the bladder. The contraction of the bladder during micturition, or what we call urination, it's going to compress that lower end of the ureter, and that compression is important. It's like a sphincter, and it's preventing reflux from moving urine back up into the ureters and then into the kidney. The issue with that, if you don't have that compression, you can introduce bacteria upward into the kidneys instead of being excreted out as urine. So peristalsis is going to be maintained even when the ureter is denervated, because ureters can also be transplanted. Now we have the sensory innervation of the ureters that come from the neural inputs from our thoracic nerve, the 10th one specifically, all the way down to the second lumbar nerve. So if anyone gets a compression injury or trauma to that area, they could have issues with micturition or urination. Ureteral pain, the pain that we get from perhaps a kidney stone in the ureter, it's referred pain from this input. And sometimes it can be referred to the flanks, the umbilicus, even the vulva or the penis. The ureters are rich in blood, and the primary arteries for the ureters are coming from the kidneys, contributing from the lumbar and superior vesicles as well. Now moving past the ureters, connecting to the bladder, we know that urine is going to empty from the ureters into the bladder. And this is a bag made of smooth muscle fibers. So the bladder is a muscle, and it forms the detrusor muscle with a smooth lining. You can see the detrusor muscle here. And it also has a uroepithelium layer. So as the bladder fills up with urine, it will start to distend, and those layers of uroepithelium are going to start sliding past each other and becoming thinner and thinner as the amount of urine or the volume of urine in the bladder will increase. This uroepithelium is forming the interface between the urinary space and then the underlying vasculature and the connective tissue, the nervous system and muscle tissue. Uroepithelium is also going to line the urinary tract from the renal pelvis to the urethra. And it maintains an important barrier function as well. It's trying to help prevent the movement of water and solutes between urine and blood. And it also provides as a communicator, trying to provide information about urine pressure and the composition to the surrounding nerves and the muscle cells. We also, what we have sometimes called the trigon. And so the trigon is this triangular area of smooth muscle here. And it's between the openings of the two ureters. So you see here an opening of the right ureter and the opening of the left ureter. This position of the bladder is going to vary with sex and with age. In females, the bladder is more anterior to the vagina and inferior to the uterus. In males, the bladder actually lies between the pubic symphysis and the rectum. Also to note, with our infants and our younger children, the bladder is positioned higher, and therefore sometimes we can palpate a little bit easier also. It has its own perfused blood supply, and this is why if there is any injury to the bladder, there usually is a lot of bleeding. So any trauma, surgery, or inflammation can cause quite a bit of bleeding in the bladder. Moving on to the urethra now. So we've moved through, and actually we're looking, hopefully you can tell if we're looking at a male or a female bladder here because of the prostate gland. This is a male bladder. And we're going through now to the urethra. It's extending from the inferior side of the bladder to the outside of the body. And you have a smooth muscle ring that forms the internal urethra sphincter at the junction where the urethra and the bladder connect. And this is under an involuntary muscle control. We also have the external urethral sphincter, and this is composed of striated skeletal muscle. This is under voluntary muscle control, right? So we can actually control whether we are trying to release urine through the urethra, through this striated skeletal muscle. The entire urethra is lined with mucus secreting glands. Whether it's male or female, there's mucus secreting glands. However, to note, a female urethra is shorter, only 3 to 4 centimeters, and the male urethra is quite long, 18 to 20 centimeters. Has to do with your anatomy, but this is also something to note when you're putting in a Foley catheter, perhaps, or an indwelling catheter. Knowing the length of the average urethra is going to help you to place that catheter in the appropriate spot. The male also has 3 main segments. We have the prostatic, the membranous, and the penile segments of the urethra. The prostatic urethra is closest to the bladder, so you can see it actually here, and it contains the openings of the ejaculatory ducts within this area. Now, sometimes, especially as men get older, the prostate gets bigger. And this prostatic enlargement can obstruct the urine flow because it's compressing that prostatic urethra. The membranous urethra passes through the floor of the pelvis, and then the penile segment will then form the remainder of the tube. It's surrounded by the corpus spongiosum, which is the erectile tissue in the penis. So what innervates the bladder and the internal urethral sphincter? It's actually going to be supplied by the autonomic nervous system. The detrusor muscle is innervated by the sympathetic nervous system, and also from the lumbar spines and the parasympathetic fibers from the sacral spinal cord area. We also have this thing called the reflex arc, and the reflex arc is required for micturition or urination. It's stimulated by mechanoreceptors responding to the stretch of the tissue, meaning that as our bladder fills up, it's sending a message saying, hey, we're getting stretched out, the smooth muscle is getting thin, and the bladder is able to sense the fullness. It sends impulses to that sacral level of the cord. When you reach about 250 to 300 mLs of urine, this is when you're going to start to have this sense. The bladder is going to contract, and the internal urethral sphincter will eventually relax through the activation of this spinal reflex arc. Sometimes this is known as the micturition reflex. So at this time, you're going to feel like you have to pee. Okay, so at the height of the micturition reflex or the spinal reflex arc, you get this urge to void, and you have a choice to inhibit or facilitate. And this happens by impulses coming from the brain. It results in this voluntary control of urination where you're able to relax, or you can contract that external sphincter. Remember, we have control over that because it is a muscular sphincter. Now, this is when everything is working correctly. And when you get into the lecture on alterations of the renal system, you'll find out that if there is an injury to the sacral level and a patient is not able to have an intact micturition reflex, then that voluntary control no longer becomes voluntary, and they're unable to control their bladder function. Now, we talked about the kidneys having its own blood supply, but just in general, the kidneys are highly vascular organs. About 1,000 to 1,200 mLs of blood per minute are circulating through the kidneys, and this is about a quarter of your cardiac output. When someone has a normal hematocrit of about 45%, There is nearly 700 mLs of blood flowing through the kidney every single minute in the form of plasma. Now, of this renal plasma, 20% is filtered at the glomerulus and it passes into the Bowman capsule. The remaining 80% is going to flow through the efferent arterioles to the peritubular capillaries. This is important because we're looking at this filtration rate. The filtration of the plasma per unit of time, we call this the glomerular filtration rate, and it directly relates to the perfusion pressure of the glomerular capillaries. The ratio of the glomerular filtrate to renal plasma flow per minute. So, for instance, 120 over 600 would give us a rate of 0.2. This is called the filtration fraction. Now, normally, all except for maybe 1 or 2 mLs per minute of the glomerular filtrate is reabsorbed from the nephron tubules and then is returned back into the circulation by the peritubular capillaries. So why are we interested in the rate of filtration? This GFR, or glomerular filtration rate, directly relates to our renal blood flow, or our RBF, which is regulated by intrinsic autoregulatory mechanisms, by neural regulation, and also by our hormones. And now, generally, blood is going to flow to any organ, determined by the arteriovenous pressure differences across the vascular bed. Now, if the mean arterial pressure decreases for any reason, or the vascular resistance increases, then the renal blood flow will decline and urinary output will then be decreased. We have autoregulation of the intrarenal blood flow in the kidney. The autoregulation of this glomerular blood flow really helps keep your GFR constant over a range of systemic arterial pressures, anywhere between 80 and 100 millimeters per mercury. This is important and very necessary in order for us to maintain the clearance of metabolic wastes that are needed to keep us healthy, and also the reabsorption of the electrolytes and nutrients that are being filtered by the renal tubules. And this is going to happen with normal variations in systemic blood pressure. So for instance, if you are exercising, your blood pressure may be increasing, you're exerting more energy, but then will decrease during rest. This is called autoregulation of intrarenal blood flow. It knows how to do it. It's being maintained by two mechanisms that are controlling the afferent arteriole. So when your blood pressure is in the afferent arteriole, when it's increasing there, intrinsically you have an autoregulatory mechanism of contraction in the arterioles, which will increase resistance. It's going to maintain constant blood flow and your GFR. Now, the absolute opposite is going to occur when there's a decrease in systemic blood pressure. We also have what is called the tubuloglomerular feedback mechanism, and this has to do with the macula densa cells at the juxtaglomerular apparatus. Reminder that the juxtaglomerular apparatus is in the distal tubule. So as your blood pressure increases, or if it decreases, the macula densa cells, they will sense the resulting increase or decrease in the amounts of sodium being filtered. Remember, they are a sensory type cell, macula densas. So when your GFR and your sodium concentration increases, then those macula densa cells are going to say, hey, afferent arterial vasoconstriction needs to happen. They're going to stimulate this vasoconstriction. It's going to then decrease the glomerular filtration rate. But the opposite happens, and it's going to decrease the GFR and sodium concentration at the macula densa whenever you have a decrease in GFR and sodium concentration. So this mechanism, called the tubular glomerular feedback, combined with our intrinsic myogenic mechanisms, are going to prevent these large fluctuations in body water and salt with the variations in our blood pressure. The neuroregulation of our renal blood flow, or the RBF, has to do with our blood vessels that are innervated by the sympathetic nerve fibers, primarily on the afferent arterioles. And so when our systemic blood pressure decreases, the renal sympathetic nerves are going to release catecholamines. The catecholamines are going to stimulate afferent renal arterial vasoconstriction to occur. With vasoconstriction, we're going to have a decrease in RBF and GFR. Thus, we're going to see an increase in the renal tubular sodium and water reabsorption. And if we're absorbing sodium and water, this is going to increase the systemic blood pressure. So in reaction to systemic blood pressure that's decreased, we release catecholamines that cause vasoconstriction, that pulls in sodium water, and therefore increases our blood pressure. So decreased afferent renal sympathetic nerve activity is going to produce then the opposite effect. We also have this hormone called renalase, and it's released by not only the kidney but the heart and other organs as well. It's promoting the metabolism of our catecholamines. And so the way it does this is it's going to participate in lowering the blood pressure and the GFR. We also have the sympathetic nervous system that participates in hormonal regulation of our renal blood flow also. Think about the renin, angiotensin, aldosterone system. Now, there's no significant parasympathetic innervation. The kidneys, the innervation of our kidneys, it's coming primarily from the celiac ganglion and the greater splenic nerve. So I mentioned the renin, angiotensin, aldosterone system just briefly, and it helps to regulate our renal blood flow. In general, hormones and these other mediators can alter the resistance of the renal vasculature by stimulating vasodilation or by stimulating vasoconstriction. And this major hormonal regulator of renal blood flow has to do with the RAS, or the renin, angiotensin, aldosterone system. And there'll be a separate short video talking about the RAS in more detail. But anyways, with this hormonal regulation of RAS, or from RAS, it's increasing, for instance, the systemic arterial pressure, and it changes the renal blood flow. Now, renin is an enzyme that's formed and stored in the juxtaglomerular apparatus, and it gets released and triggered by a decrease in blood pressure. So whenever our body senses that our blood pressure is low, renin gets released in the afferent arterioles, and then decreased sodium chloride concentrations in the distal convoluted tubules will then occur. We also have sympathetic nerve stimulation of the beta-adrenergic receptors that are located on the juxtaglomerular cells, which are releasing prostaglandins. Now, these physiologic effects of the RAS will stabilize our blood pressure automatically if our RAS is intact, and it will preserve the extracellular fluid volume during periods of hypotension or hypovolemia. So it's trying to keep an equilibrium. Now, what does it do? It can include sodium reabsorption, systemic vasoconstriction. It can stimulate the sympathetic nerves. It can stimulate thirst. And it will then obviously provide an increase in fluid intake. Now, the effects of aldosterone combined with antidiuretic hormones, or ADH, will help regulate your blood volume. And we're going to talk more about that in a separate presentation. And we talked a lot about the nephron being a functional player in the formation of urine, but it also can perform other functions simultaneously. It filters our plasma at the glomerulus. It can help with the reabsorbing and the secretion of different substances along the tubular structures. It helps forms filtrates of protein-free fluids, and it can help with the regulation of the filtrate to maintain an appropriate body fluid volume, electrolyte composition, pH, and keeping it within the narrow limits. When we think about glomerular filtration,
we have to understand that really what we're measuring is the movement of fluid and solutes that are going across the glomerular capillary membrane into that Bowman space. It's also important to note that not only are we thinking about water, but we want to make sure that it's impermeable to the larger molecules such as proteins. When we talk about tubular reabsorption, this is the movement of fluids and solutes from the tubular lumen into the peritubular capillary plasma. And these secretions are a transfer of substances that occur from the plasma of that peritubular capillary then into the tubular lumen itself. So the transport mechanisms that you have to remember are active transport and passive transport. And these processes we've already covered in previous chapters. And finally, we talk about the excretion. This is the elimination phase of the substances in what we call urine. So this is when everything gets filtrated, what needs to get reabsorbed gets reabsorbed, and then what needs to be secreted and excreted are doing so, and that substance is urine. Now, this fluid that's filtered across the capillary filtration membrane, these are protein-free, but they can contain electrolytes like sodium chloride and potassium. You might even have some organic molecules like creatinine, urea, and even glucose, depending on the concentrations that are found in the plasma. Now, the glomerulus is a freely permeable space. It's permeable to water, but remember, it's impermeable to those large colloids and the plasma proteins, which we talked about earlier. Additionally, including the permeability, this capillary pressure also is going to affect that glomerular filtration rate. Hydrostatic pressure occurs within the capillary, and hydrostatic pressure is the major force for pushing water and solutes across this filtration membrane, and again removing it into that Bowman capsule. So the two forces that are opposing this filtration effect is the glomerular capillary hydrostatic pressure, which is the hydrostatic pressure in the Bowman space, and the effective onconic pressure of the glomerular capillary blood. So again, we have the hydrostatic pressure within the Bowman space, but then we also have the onconic pressure of the glomerular capillary blood. So do you remember learning about hydrostatic pressure? This is the pushing pressure. But onconic pressure is a pulling pressure. And when we talk about onconic pressure, what are we pulling? We're thinking about it in terms of its relationship to water. Now, because the fluid in the Bowman space usually contains only very small amounts of protein, it doesn't have any onconic influence, right? Because this onconic pressure comes from plasma proteins. So it usually does not have an onconic influence on the plasma of the capillary or the glomerular capillaries. Okay, but more specifically, this filtration rate is measuring the total volume of all the fluid that's filtered by the glomeruli, which averages for most adults about 180 liters a day. That equates to almost 120 milliliters every minute. So you have to constantly think about this in terms of the size of the kidney itself. Such small organs are able to filtrate so much fluid. Now, because only 1 to 2 liters of urine is excreted per day, that means that 99% of all the filtrates is being reabsorbed. Where is it being reabsorbed? Into the peritubular capillaries. Why do we need it to be reabsorbed? Because it needs to go back to the blood. It's returning its way back to the blood. Also, think about the factors that determine your GFR in the first place. What are they related to? It's related to the pressures that favor or oppose filtration. Also, if perhaps there's some type of obstruction of the flow of urine that could be caused by perhaps a urinary stricture, a kidney stone, or even a tumor anywhere alongside that urinary tract, this can cause a retrograde increase in hydrostatic pressure. Retrograde meaning it's going the opposite way of what we want it to do. It's going from below to higher. And this increase, or retrograde increase in hydrostatic pressure at the Bowman space, along with a decrease in our glomerular filtration rate, can occur. Whenever we have low levels of plasma protein, this can result in a decrease in our onconic pressure. Well, it is inversely related to our GFR. So if there's a decrease in onconic pressure, there's going to be an increase in glomerular filtration rate. Whenever there's a situation where perhaps you might have a patient and they are excessively losing protein-free fluid, well, what type of patient would that be? It could be someone that is excessively vomiting or has excessive diarrhea, or maybe you have a patient that's on diuretics. What if you have a patient that is excessively sweating, right? All of this loss of volume and fluid can actually increase that onconic pressure and then decrease your GFR. But what about renal disease? This can cause changes in pressures also. And they do this by altering capillary permeability and the surface area that's available for filtration in the first place. So please use this schematic here, this drawing that tells you what is going on with the opposing filtration and the net filtration pressure to understand our capillary onconic pressure and our glomerular capillary hydrostatic pressures. Now we're going to look at what actually happens when we have our filtrate moving through the glomerulus within the Bowman space. Once it passes that and we get to the proximal tubule, about 70% of all the filtered sodium in water and about 50% of urea have already been actively reabsorbed. Additionally, 90% or more of potassium, glucose, bicarbonate, calcium, phosphate, amino acids, and uric acid have also been actively reabsorbed. Chloride, water, and urea are reabsorbed through active transport of sodium. It's this co-transport mechanism, and they work together for the achievement of passive reabsorption. For some molecules, active transport in the renal tubules is pretty limited because carrier molecules can become saturated. This is called transport maximum. Let me give you an example. If a patient is hyperglycemic, the carrier molecules for glucose reabsorption in that proximal tubule can become saturated. The excess of this glucose needs to go somewhere because of the hypersaturation. So it gets excreted in the urine and it can cause glucosuria in your patient. Active reabsorption of sodium is the primary function of the convoluted segment of the proximal tubule. It's its main job. Now, water and most of the electrolytes and organic substances, they are the co-transported molecules that move with sodium. And the osmotic force that's generated by this active sodium transport is promoting the passive diffusion of water out of the tubular lumen and moving it into the peritubular capillary. Passive transport of water is important. It's going to further enhance and become partners with elevated onconic pressure of blood. The reabsorption of water is leaving an increased concentration of urea inside that tubular lumen. This is important because by increasing the concentration of urea, you're also creating a gradient for a passive diffusion in the peritubular plasma. So now we are left with positively charged sodium ions leaving the tubular lumen, but in exchange, we are gaining negatively charged chloride ions that are passively following. And this process is called electroneutrality. Specifically, bicarb or bicarbonate is completely filtered at the area of the glomerulus, and about 90% is being reabsorbed in that proximal tubule space. So in the tubular lumen, we have hydrogen ions being actively exchanged for sodium, but these hydrogen ions will eventually combine with bicarbonate ions, and when they come together, they are forming carbonic acid. Okay, so you have hydrogen ions combining with bicarbonate ions to form carbonic acid. But carbonic acid usually rapidly breaks down and it's going to disassociate over time. When it disassociates, now it becomes carbon dioxide and water. And the CO2 and H2O will eventually diffuse into the tubular cell where the enzyme called carbonic anhydrase will then again catalyze that CO2 or that carbon dioxide. And it's also going to catalyze the H2O or water. It's going to form a hydrogen ion. Now this hydrogen is secreted into the tubular lumen. Once again, it combines with sodium, but now it's being transported to the peritubular capillary blood, but its form is now sodium bicarbonate buffer. The hydrogen will then combine with the hydrogen ion, and this gets reabsorbed as water. In the proximal tubules, secretory transport mechanisms exist for creatinine, can also exist for organic bases, endogenous and exogenous organic acids, including penicillin. These secretory mechanisms are important. Think about how we eliminate drugs and other exogenous chemicals from our body. First, we combine or conjugate them with sulfate and glucuronic acid in the liver. And because many drugs and their metabolites are eliminated through this process, when the renal tubules are damaged, the byproducts of the metabolites and the drugs can accumulate. And if they accumulate and they don't get excreted appropriately, this can cause toxic levels in your patient. Within the loop of Henle in the distal tubule, we are now going to have the concentration of urine. And urine can be either hypotonic, isotonic, or hypertonic. It really depends on the concentration of the urine or the dilution of the urine. And this is the principal mechanism within the loop of Henle. Also the distal tubules and the collecting ducts. The transition of the filtrate into that final urine really is a reflection of how the concentration tasks, if you want to call that, is happening within the loops of Henle. Now, the final adjustments in the urine composition are going to be made once it's in the distal tubule and the collecting ducts. And it's going to be according to what the body needs. But the majority of this concentration is happening again within that loop of Henle. You might have noticed in the previous slide where it said countercurrent exchange system. Well, the production of the concentrated urine involves this countercurrent exchange system. Fluid flows in opposite directions through parallel tubes of the loop of Henle. Remember, the loop of Henle is where the concentration of urine primarily takes place. Well, within these parallel tubes, there's a concentration gradient, and it's causing fluid to be exchanged across these parallel pathways. So the longer the loop, the greater the concentration gradient is going to be. And this gradient increases from the cortex to the tip of the medulla. The loops of Henle multiply the concentration gradient, and the vasa recta blood vessels, remember they are around the loops of Henle, they are going to act as a countercurrent exchanger because they have the task of maintaining this gradient. How is this process initiated in the first place? This process is going to be initiated in the thick ascending limb of the loop of Henle, and it's being initiated with active transport of both chloride and sodium, and it's moving out of the tubular lumen into the medulla or the medullary interstitium. Because the lumen of the ascending limb is impermeable to water, water at this point can't follow the sodium chloride transport. What happens then? The ascending tubular fluid becomes hypoosmotic, and then this is going to lead to the medullary interstitium to become hyperosmotic because they have a inverse relationship. Okay, so this is describing that countercurrent exchange system. So we know now that the urine concentration primarily happens at the loop of Henle. But let's think about the urine composition in general. Urine is normally a very clear yellow and sometimes amber. It really depends on its concentration, right? Or how much water a patient may be drinking, or how much of the solutes are being excreted within the urine. And therefore, cloudiness can indicate either the presence of cells, bacteria, or a very high solute concentration. Normally, the pH of urine is going to range from 4.6 to 8. However, generally, urine is normally acidic. Why would we want acidic urine? Acidity provides protection against bacteria. The specific gravity usually ranges from 1.001 to 1.035. Anywhere beyond this range would cause a difference in concentration. So anything lower would be very low concentration of urine, and anything higher than 1.035 would be a higher concentration of urine. And normally when you get urine samples, again, they're clear yellow, they're amber, but they shouldn't contain glucose or blood cells. Occasionally you might see traces of protein, but glucose and blood cells are not normal. What if you do see glucose? Remember our example of highly saturated glucose in the tubules? They need to spill out, and they spill out in the urine, and this is called glucosuria. Well, blood, there could be a number of reasons, and we're going to get to that in our slides when we talk about the alterations in renal function. But for instance, it could be a urinary tract infection, but it also could be something with the bladder, like bladder cancer. What would cause traces of protein to spill out into your urine? Usually, this is associated with very rigorous exercise. Otherwise, you're looking for some type of abnormality and perhaps a situation where onconic pressure is disrupted. We can't talk about the kidneys without also talking about hormones and the actual function of the nephron. And the first hormone I want to talk about is the antidiuretic hormone. The distal tubule in the cortex is going to receive that hypoosmotic urine from the ascending limb of the loop of Henle. The specific gravity, or you can also say the concentration of urine, is controlled by this antidiuretic hormone, or ADH. It's secreted from the posterior pituitary. You might remember that from your endocrine lecture. ADH will increase water permeability. It's an antidiuretic hormone. By increasing water permeability and reabsorption in the last segment of the distal tubule and along the entire length of the collecting ducts, it's also passing through the inner and outer zones of the medulla. This water is diffusing into the ascending limb of the vasa recta, and it returns to the systemic circulation because it's going to help to maintain our fluid balance. Antidiuretic hormone, when someone does not have enough of antidiuretic hormone, it could possibly cause them not to diurese, right? Because it's antidiuretic. And so it's causing the patient to hold on to the urine versus excreting it. Did you know that in the evening and at night, our ADH levels usually increase, causing us to have more concentration of urine and less fluid? This is beneficial to us because it helps us not to wake up in the middle of the night to have to urinate. Because the concentration is increased, we don't have a lot of volume. It's not going to trigger that reflex arc to tell our bladder we need to void. The excreted urine can have a high osmotic concentration up to 1400. The volume is normally reduced to about 1% of this at the glomerulus, however. Aldosterone is also a hormone that is synthesized and secreted by the adrenal cortex under the regulation of the RAS. Aldosterone stimulates our epithelial cells within the distal tubule and the collecting ducts to reabsorb sodium. So this is going to promote water reabsorption because wherever sodium goes, water goes. And it's also going to then inversely increase the excretion of potassium and hydrogen ions. So think about this in terms of the RAS. Why would holding on to sodium be a good thing? Well, let's say someone has low blood pressure and our RAS, our renin, angiotensin, aldosterone system is sensing this, then it's going to reabsorb sodium so that we can hold on to water, therefore hopefully increasing the blood pressure and maintaining an equilibrium. We also have natriuretic peptides, which are a group of peptide hormones that promote sodium and water excretion. This also includes our ANP, which is called our atrial natriuretic peptide, or sometimes we refer to this as the A-type natriuretic peptide, and it's secreted by our myocardial cells in the atria, so our heart cells, and also can be excreted in the brain. When it's excreted in the brain, we call this the brain natriuretic peptide, or BNP, or B-type natriuretic peptide. This gets secreted by the myocardial cells within the cardiac ventricles. So when your heart dilates during volume expansion, or if you have heart failure, your ANP and your BNP will inhibit sodium and water absorption by the kidney tubules. It inhibits the secretion of renin and aldosterone, vasodilates the afferent arterioles, and it will constrict the efferent arterioles. So the result is the increase of urine, which will then lead to a decrease in blood volume and blood pressure because you're releasing fluid. The body is so smart in that way. It's a feedback mechanism. We also have a C-type natriuretic peptide, which is secreted by the vascular endothelium. C-type natriuretic peptide, or sometimes called CNP, causes vasodilation within the nephron and complements the action of ANP and BNP. And lastly, of the natriuretic peptides, we have urodilantin. And this is a peptide that's secreted by the distal convoluted tubules and collecting ducts. It also causes vasodilation, and it has a similar effect to the natriuretic and diuretic effects we're looking for. Remember, if we have antidiuretic that keeps the fluid in, we also have diuretics, and this is the factor that we need to consider within urine flow. A diuretic is anything that enhances the flow of urine, any agent that enhances that urine flow. So clinically, we know that diuretics will interfere with the renal sodium reabsorption, and it reduces that extracellular fluid volume. Why do we use diuretics? Well, if we have hypertension, we can use diuretics to diurese or release some of that fluid, bringing down the blood pressure. We also use it with patients that are very edematous, and maybe this edema is caused by cirrhosis or heart failure, or maybe they have a nephrotic syndrome. We can use diuretics to reduce that fluid volume. However, on the flip side, if you are diuresing someone and releasing a lot of fluid, you have to be careful not to dehydrate your patient. Remember, wherever fluid goes, we have to think about what happens to the electrolytes as well. It can result in hypokalemia, systemic acidosis, possible metabolic alkalosis. It can also cause your patients to feel very nauseated and have a headache. Other renal hormones that are as important are vitamin D and erythropoietin, and they're activated or synthesized by the kidneys. Hormones have significant systemic effects, which we've also seen in urodilatin in the previous slide. And now we're going to talk about what happens with the active form of vitamin D and erythropoietin. Specifically with vitamin D, we know it's a renal hormone and it's necessary because without it, it doesn't matter how much calcium you eat or drink, you can't absorb the calcium. So you need vitamin D. But also vitamin D is important for the absorption of phosphate, and this happens in the small intestines. Normally the concentration or the serum concentration of vitamin D is 50, and it can be obtained in either diet or we can have it synthesized by ultraviolet radiation, or what we would call going out in the sun. These forms of vitamin D3 are called cholecalciferol. Okay, and this is when you are getting vitamin D through a supplement, and it's inactive until you have hydroxylations, which add a chemical compound to make it a metabolic active form of vitamin D. So the first part of this hydroxylation, remember we need 2 hydroxylations. That first one happens in the liver and the second one happens in the kidneys. What stimulates the renal hydroxylation? It's the parathyroid hormone. When you have a decreased plasma calcium level, it's going to stimulate the secretion of the parathyroid hormone. And then this hormone will stimulate a sequence of events that will eventually help the plasma calcium concentrations to return to a normal level. Calcium mobilization from bone, synthesis of 1-25 dihydroxy vitamin D3, and the absorption of calcium from the intestines, increased renal calcium reabsorption, decreased renal phosphate reabsorption, And fluctuations in the serum phosphate concentration are all influenced by the hydroxylation of vitamin D. So you can see how important this two-step hydroxylation is. Decreased levels will then stimulate an active 1,25 dihydroxy vitamin D3 to form, and increased levels will inhibit the formation. So there's a negative feedback loop. The result is going to be then, to compensate for all of this, phosphate reabsorption or absorption from bones and the intestines. So think about someone with renal disease. If they have a deficiency of the 1,25 dihydroxy vitamin D3 and they start to have symptoms of disrupted calcium and phosphate balance, this would make sense because you're not getting that feedback loop mechanism working to create an equilibrium of those electrolytes. So vitamin D is necessary for the absorption of both calcium and phosphate. Well, what about erythropoietin? Erythropoietin is stimulated by our bone marrows, and it's trying to help the bone marrow to produce RBCs or red blood cells. Well, why would we need this? Well, if our tissues become hypoxic or there are some deficits in RBC levels, then erythropoietin kicks in, tells our bone marrow it's time to make more. And remember, red blood cells only live about 120 days anyways. But what stimulates EPO to be released, or erythropoietin? It has to do with our oxygen delivery. Okay, so the stimulus for EPO release is decreased oxygen delivery to the kidneys. So we have these oxygen sensing erythropoietin producing cells. They're all along the peritubular areas, and it's located in the juxtamedullary cortex. So think of anemia that occurs due to renal failure. Now the kidneys are non-functional. This can also be related to the lack of erythropoietin hormone as well. So can you answer, why do we need erythropoietin? We need it because it's going to stimulate our RBC production. And obviously we can't live without red blood cells. When does it get released? Whenever there is a decreased oxygen state within the kidney. And remember, we have these oxygen sensing erythropoietin producing cells that lets the body know. Let's practice. You have a patient that is experiencing diuresis. So what actually explains this process? Is it an increase in renin? Is it an increase in aldosterone? An increase in antidiuretic hormone? Or an increase in atrial natriuretic peptide? If you said natriuretic peptide, you're correct, because natriuretic peptides cause vasodilation. When we have vasodilation, it's going to increase that sodium and water excretion because now we have more area for fluid to be diuresed. Well, when we have a release in fluid, what happens to our blood pressure? It's going to decrease that blood pressure. What were those natriuretic peptides anyway? Remember urodilantin? This is a renal natriuretic peptide, and it increases renal blood flow, which will cause diuresis. An increase in renin will produce an increase in aldosterone. Well, when we have a lot of aldosterone, this is going to stimulate the epithelial cell of the distal tubules and the collecting duct to then reabsorb sodium. What are we promoting when we are reabsorbing sodium? We're also promoting water reabsorption as well. And lastly, antidiuretic hormone secretion is the cause of oliguria. What is oliguria? This is when we have less excretion of urine than we would like. So, to quantify this, it's either less than 30 mLs an hour or 400 mLs a day.